Welcome, everybody. I will be discussing current therapeutic strategies for phototherapy and systemic therapy. These are my disclosures. None of these really should be relevant to what we'll be discussing today, although may be relevant overall. I will try to present a fair and balanced presentation. So let's start off with phototherapy. And really to frame this conversation and really the next few slides, we are fortunate to have a recent Cochrane systematic review that was performed that really assessed the level of evidence that we have to support the efficacy for various interventions in hand eczema. And this is just a small part of one of the tables in that manuscript, examining, the studies out there for phototherapy, particularly with ultraviolet B as a modality versus either different study designs, either placebo or versus topical PUVA. And we have some varied results, but when looking at investigators' assessment of good or excellent control, we have multiple studies that have shown significant improvements for local UVB therapy versus placebo, versus whole body plus hand UVB, and even versus topical PUVA, although with a smaller effect size. So we have a demonstration of efficacy for ultraviolet B light. We also do have a demonstration of efficacy for topical PUVA and other light modalities. And often the choice of modality will really vary by region in terms of which devices are available and what is considered sort of normative use in different regions. With respect to oral interventions, really the go-to agent for many clinicians around the world, and I'm sorry to say it's not, unfortunately, not my go-to agent because I don't have access to it, but for many regions around the world is alitretinoin. And we have some pretty good evidence that alitretinoin is effective in hand eczema in a dose-dependent fashion. Looking at the 10 milligram dose, we have several studies showing that there's improvements in terms of investigator-rated symptom control compared with placebo. Not necessarily an enormous effect size, but number needed for treatment benefit for 11 patients over topical therapy. And then also significant improvements in subjective outcomes or patient-reported outcomes in terms of symptom control. And we see an even stronger effect size when we look at the alitretinoin 30 milligram dose compared to placebo, where the number needed for treatment benefit over topicals would be 4, and we have a larger effect size in terms of relative risk for improvement. And this evidence was rated as high certainty. Now, there are adverse events, but overall well tolerated, but the number of adverse events, including headache, in this case was rated as probably not differing between alitretinoin 10 milligram and placebo, but the risk of headache increased with alitretinoin dosed at the 30 milligram, and that was felt to be a high certainty of evidence. So we see a little bit of an increase in adverse events, but overall a demonstration of good efficacy. Now, cyclosporin is an option that we are certainly familiar with across many inflammatory disorders, certainly in atopic dermatitis. And we know that dose matters, but there are studies that have examined oral cyclosporin A at a 3 milligram per kilogram daily dose and found that cyclosporin probably slightly improves investigator-rated control of symptoms and participant-rated control of symptoms. We don't have an enormous amount of studies here, and this was compared to the background of topical betamethasone after 6 weeks of treatment. And we certainly do see an increase in risk of adverse events, dizziness, and of course, there's a well-established side effect profile for cyclosporin. And in this case, the evidence was rated as moderate certainty of evidence. So those are sort of the options that could be voted on or rated in a sense in terms of the level of evidence because there were enough studies. After that, many of the studies really come down to retrospective or case control or a case series and things like that, but not really necessarily controlled studies. So how do we put this together with the level of evidence that we have and what we know about existing therapies for atopic dermatitis? And there are a variety of different guidelines that have been developed over the years for how to use therapies in general or systemic therapy in particular for hand eczema. This is one of the earlier guidelines developed. This is a consensus guideline, including a panel of dermatologists and a general practitioner who had a special interest in dermatology. And you can see this flow chart on the right. It is a complicated figure, but I want to draw your attention particularly to the rightmost panel along the edge and really going to the lower part of that. Thinking about, in that rapid control category, cyclosporin or oral steroids may fit into that. We know that those are agents that tend to work quite quickly, but unfortunately are often quick fixes and aren't great for long-term management. When we get into hyperkeratotic or vesicular hand eczema, topical PUVA is an option. Cyclosporin again could be potentially used. And here we see alitretinoin appearing as well. And then for hyperkeratotic, this particular guidelines recommended acitretin. We do see a little bit less efficacy of alitretinoin in that hyperkeratotic subgroup. I'm not sure acitretin is all that much better. It may just be a tougher to treat subset in general. And then here, other agents like methotrexate and mycophenolate are positioned as sort of second line or last ditch efforts if one has already failed alitretinoin or cyclosporin, etc. Other guidelines have been developed, and the German Dermatologic Society guidelines and Canadian guidelines recommend the use of high potency topical corticosteroids, ultraviolet therapy, and again, alitretinoin as that recommended treatment approach. And then as a last resort, other systemic treatments such as cyclosporin. Now, in terms of the US experience and my own sort of anecdotal personal experience with systemic therapy for hand eczema, we don't have formal guidelines for hand eczema in the US. Narrow band ultraviolet B is generally the predominant modality of phototherapy available. It is often considered to have a better safety and tolerability than PUVA, but it is a relatively slow onset of efficacy, which is leaves important unmet needs. And often is inadequate in terms of the efficacy for patients. The biggest challenge, of course, with phototherapy in general, but certainly in the United States, is just access. Is so limited for so many patients. There's not enough phototherapy sites. The hours are limited. It's hard for patients who work or caregivers. We very unfortunately do not have alitretinoin approved in the United States. And so when we think about all of the published guidelines leaning so heavily on alitretinoin as a go-to option, that is unfortunately not our reality in the US. The cyclosporin, of course, works well short-term, but generally should not be used for long-term maintenance. I find that it often requires even higher doses than 3 milligram per kilogram just as a starting dose in tougher cases of hand eczema. And of course, we know the challenges of safety, tolerability, and laboratory monitoring. Anecdotally, I happen to like using methotrexate very much. I kind of lean on methotrexate the way maybe the rest of the world would lean on alitretinoin. Often requires higher doses though, and often is inadequate efficacy, and particularly for profound xerosis and that hyperkeratotic subset. And really, as a close, now more and more we're starting to use dupilumab, off-label, in some cases this is on-label for hand eczema in the context of more generalized atopic dermatitis, and we see good results. And then perhaps more off-label, if you will, for isolated hand eczema. And with that, I think you'll hear a lot more about dupilumab, particularly for hand eczema, in the next talk from Dr. Gutman. And so with that, I would like to thank you for your attention, and I hope you enjoy the rest of the seminar.